Now we're going to discuss some cardiology issues, and most of what we're going to discuss with cardiology is going to be congenital heart disease. The evaluation of the patient, a pediatric patient, is a little bit different than in adults, particularly the history and the manifestations of cardiac disease in children. Remember, the history is very important. Children, when they go into heart failure, don't necessarily present with the same signs and symptoms that adults will. Obviously, as they get closer to adult age, size, and pathophysiology, they will. But infants, for example, can present in congestive heart failure with very nonspecific signs and symptoms, such as feeding difficulties. They can also get tired easily. Many times they get tired while they're feeding. They can sweat while they feed. That's a common complaint. And they can have tachypnea and poor weight gain or failure to thrive. You're not going to hear about a little baby having dyspnea on exertion or orthopnea because they don't even use pillows. The older child will start manifesting some shortness of breath. They might tell you that they can only walk so many steps before they get tired. And then obviously, as they get older, can have orthopnea and dyspnea. But look at the age when you're reading the question, because the signs and symptoms will be a little bit different. The physical exam in a child, as far as cardiac concerns, you need to know normal heart rates. Remember that tachycardia in one age is normal in the other. A baby is born and has a normal heart rate of 120 to 140. That's not a big deal. Certainly a 6-year-old with a heart rate of 120, that's of concern. Also, part of the exam includes assessing adequate growth, and so growth charts are very important for the cardiologist because with chronic problems, they may have failure to thrive, they may have short stature, and so all these weights and heights need to be plotted at every visit to make sure that the patient is doing well and at least gaining weight appropriately. It is extremely important to assess upper and lower extremity blood pressures on every single visit. This is one quick way of searching for coarctation of the aorta. Also, another part of the physical exam is assessing pulses, upper and lower extremity pulses. RALs can be evidenced on physical exam, and this would be evidence of left-sided failure. Hepatomegaly would be evidence of right-sided failure, and obviously if you have RALs and hepatomegaly, you'll be thinking of biventricular failure. Cyanosis and clubbing, remember that clubbing occurs in any chronic hypoxic state, so patients with, for example, cystic fibrosis can have clubbing, but also patients with cyanotic heart disease will have clubbing. You need to know your qualifications or your descriptions of murmurs when we talk about the heart exam. You may get a test question and it will describe a murmur, so you need to know the description of the murmur and you need to know what they're talking about. It's just that you need to know the language. So we're going to go through the quality and the grades of murmurs, and we're going to use sound as an example. A grade 1 murmur is very low. It's very hard to hear. It's very soft. A grade 2 murmur is very easy to hear. Just about anyone can hear it with the stethoscope. You don't have to be a real good cardiologist for that. A grade 3 murmur is a little bit louder than a grade 2, but a grade 3 murmur does not have a thrill associated with it. When we start talking about thrills, and a thrill is something that you palpate, you put your hand on the baby's chest and it feels like a cat purring. That's a thrill. Now we're talking about 4, 5, and 6. A grade 4 murmur is louder than a 3 and has a thrill associated with it. A grade 5 murmur is even louder than a 4, and you can hear it with your stethoscope partly off the chest. And a grade 6 murmur is the loudest murmur of all, and you can actually hear it with your stethoscope just off the patient's chest. Those are your 6 grades of murmurs. When you're reading the test question, they will give a murmur and they'll say what grade it is, and this will help you because when we talk about innocent murmurs, it'll be very helpful to know the classification of murmurs. Some of the tests that we use for children in cardiology are the same as for adults, and some we can't do because, for example, we can't put an infant on a treadmill. So some of the tests are the same and some aren't. Chest x-ray is always a good first test to look at heart size, also to look at pulmonary blood flow by looking at the pulmonary vascular markings. The electrocardiogram is also helpful. You can find right atrial enlargement, left ventricular hypertrophy, things like that, just like you would read an electrocardiogram on an adult. Now, the voltage criteria are a little bit different, so I doubt that they'll be giving you an electrocardiogram to interpret in a child. The echocardiogram is the best test for diagnosing congenital heart disease. So since it's the best test and it's used on every single patient, you're probably not going to get asked to order an echocardiogram. They will give you results or findings or something, because everybody's going to get an echo if you suspect congenital heart disease. MRI is sometimes used on children also, and children undergo cardiac catheterizations and angiography, and age appropriately they can have exercise testing. So you can put an older child on the treadmill and do exercise testing. Let's discuss innocent murmurs, because like the rest of pediatrics, you may get asked questions about normal things. They may be normal in children and not in adults. And if you're in an adult mindset, when you're taking the test and you're doing a pediatric question, you might think that something is abnormal in this child, and it's not. So we're going to discuss the innocent murmur. An innocent murmur, or let's talk about the pathologic murmur. The innocent murmur is the opposite of that. The pathologic murmur is considered, the murmur is considered pathologic if there are some signs and symptoms associated with it. So if they're telling you about shortness of breath, or they're telling you about cyanosis, things like that, then obviously that's not an innocent murmur. If it's grade 3, 4, 5, or 6, it's not an innocent murmur. Now, there are pathologic murmurs that can be 2s. But if they're describing in the test question a 3, it is not an innocent murmur. You need to think of it as a pathologic murmur. If there's a thrill associated with it, well, by definition, that makes it a 4, 5, or 6. So if there's a thrill associated with it, it is not an innocent murmur. It's a pathologic murmur. If the murmur that's described is diastolic, then it must be a pathologic murmur. There are pathologic murmurs that are systolic, but all innocent murmurs are systolic. So if they're describing a diastolic murmur or a diastolic component, it is no longer considered an innocent murmur. Think of a pathologic cause. If they describe abnormal heart sounds, gallops, things like that, then you have to consider that a pathologic murmur. And if the pulses are abnormally strong or weak, then it's a pathologic murmur. Typically, an innocent murmur is at around 3 to 7 years of age. It's about a grade 2, has a soft musical quality to it, and the child is fine. So you may get a test question where they say that a child is 5 years old, here for a routine visit, is at the 50th percentile for weight and height, is doing great, the parents have no concerns, has always been fine, and a murmur is detected. You don't need to do anything for that child. You don't need to consult a cardiologist. You don't need an x-ray. If it fits the criteria of an innocent murmur, reassurance of the parents is all you need to do. Let's discuss normal fetal circulation, because if you go over this, then you can understand the plumbing problems that occur with congenital heart disease. Remember, the source of oxygen for the fetus is the placenta. So oxygen is going to come from the umbilical cord, from the placenta, umbilical cord, and the blood will then travel to the heart. Now, in utero, the patient still has some connections. There's going to be a patent foramen ovale, and you're still going to have a patent ductus arteriosus right up here. So that blood basically bypasses the lungs in the fetus. There's no need to get oxygen there. You're getting the oxygen through the placenta. Blood bypasses the lungs pretty much by going across the patent ductus arteriosus and across the foramen ovale. And that's how it reaches systemic. The lungs are a low-flow, high-resistance field in utero. When the baby is born and the cord is now clamped, the baby starts to take a breath, the lungs expand, and the lung fields now become a high-flow, low-resistance field. A couple of things happen over the first few days. Oxygen tensions cause the ductus arteriosus to start to close. And it closes over several days, and anatomically it'll close completely in a couple of weeks. But functionally it takes a few days. And the foramen ovale tends to start to close up also around the first few days. And now we then have the normal adult circulatory pattern once the baby is born. You have to remember that and review that so that you can figure out which way blood is flowing when we discuss certain heart pathology. Most congenital heart disease is going to be diagnosed by 1 month of age, particularly serious congenital heart disease because they'll be cyanotic or going into heart failure. You need to remember that murmurs may not be present at birth. That's because it takes a while for the pulmonary vascular resistance to drop. The only way that you're going to hear a murmur is as it flows through the defect. And the only way you're going to have flow through the defect is if there's a difference, a pressure gradient. And until the pulmonary artery pressures drop, the smaller pulmonary vessels, until the pulmonary vascular resistance drops, and then there's a gradient, you may not hear the sound of the blood going through the defects. So it sometimes takes weeks or months for them to develop. Remember that if you have something wrong with one part of your body, a baby may have something else wrong, so that patients with congenital heart disease may have other congenital abnormalities, up to a third of them do. The majority of congenital heart disease, we don't know what causes it, but we do know it's some syndromes are associated with it, like Down syndrome, like Edwards syndrome. We also know that there are some teratogens associated with it, such as alcohol. We're going to try to divide the heart diseases here to make it a little bit more convenient. Some heart diseases are stenotic heart diseases, and those are obstructive outflow tract obstructions, and some are shunting diseases. And when we talk about shunting, talk about right to left shunting, and right to left shunting results in cyanotic heart disease. Left to right shunting usually does not result in cyanotic heart disease. However, over time, remember that left to right shunting causes increased pulmonary vascular resistance. The pulmonary arteries start to remodel to limit the amount of blood flow to the lungs. At some point, the pulmonary vascular resistance is equal to the systemic vascular resistance, and if it continues, the pulmonary vascular resistance can actually be higher than the systemic vascular resistance, and that's when the left to right shunt can then become a right to left shunt, and that's what we call Eisenmenger complex. And then we have the mixing lesions. The mixing lesions can be cyanotic depending on the amount of mixing that occurs. And so that's the determining factor whether a baby is going to be blue or not, is the amount of mixing of deoxygenated blood with oxygenated blood. Another important point to remember is that blood is oxygenated or deoxygenated, but even deoxygenated blood has oxygen in it. It's not unoxygenated blood, so we can sometimes use that deoxygenated blood and it keeps us going until we can fix the problem. And you have a listing there of the actual diseases and what categories they fall under, and we'll discuss them shortly.